Here we go, the last session of the day. I think we'd have to pretty be confident to say that it's been a pretty excellent day so far, I think. So that's fantastic. I do want to keep on time because I am mindful that people have got planes to catch, so I really don't want to run over time. So we'll move on with our next speaker. So our next speaker is Julie Sharrock. Julie is a credentialed mental health nurse working in general specialist psychiatry, drug dependence and education. Julie works to integrate mental health care into all care by working with patients, but also with staff through increasing their capacity to attend to the mental health needs of patients. In particular, Julie has a strong interest in supporting nurses to manage the often intense emotional work of caring for people facing life-threatening or life-changing illnesses. So please welcome Julie.
Thank you, and I'd also like to acknowledge the traditional custodians of the land we meet here today. And I was just trying to find where Leslie's sitting, or is she? Oh, okay. I hope she's coming back in because I did want to acknowledge and make some links to her presentation. But the lass I'm going to be talking about is from one of the mobs down south, so it sort of ties in nicely, her presentation, to what I'm going to talk a little bit about today. So we've got half an hour and I'm going to talk about two of the things that I feel very passionate about. So for me to keep to time was a real challenge. So I hope I'll manage to, and Kim's going to make sure I do. So the two passions are working in as a mental health nurse consultant in general hospital settings. I'm passionate about putting mental health care into the general hospital setting. The other thing I'm passionate about is clinical supervision. So they're the two things that I want to touch on today. So let's see how I go. And interestingly enough too, Leslie mentioned about having all mental health professional in all end-stage illness settings, and I am just waiting to hear that my contract has been confirmed to work 8 hours a week in our dialysis unit. I'm not going to start doing haemodialysis, but I am hoping to work from a mental health perspective. Is there any dialysis nurses in here at all? Yeah, just a couple, just one or two? Okay. So that's what I'm hoping to do when I get the contract signed. So I'm not going to give you any stats because I think we've probably had enough of them. Am I pointing that the wrong way? Yes, I am. And I'm not going to talk too much about comorbidity. I just want to share with you what I find in the general hospital, which are the most common mental health problems that I see in the group of people that we look after in the general hospital. And it's most commonly the high prevalence disorders. We've heard a lot about depression and anxiety today. The next three, adjustment difficulties, personality disorder, substance misuse, the next four, and history of trauma in the past, they're sort of diagnostic groupings, if you like, that are a bit broad and in some ways ill-defined. There's certainly a lot of stigma associated with personality disorder and substance misuse, and they're all linked together, but for some people. And the case I want to just give you a little bit of a window into will highlight the challenge that I find is the group of people who don't adjust well are the ones that they're more likely to call the nurse about to help them with caring for the person who's chaotic, non-compliant, not taking on the warnings and threats or risks seriously, and living in the past and the moment, as Leslie talked about. Cognitive disorders, of course, which is delirium and dementia mainly. Somatisation, so those illnesses where the mind speaks through the body, poorly identified, poorly managed as a general rule in the hospital settings. And the low prevalence disorders, that's the smallest component of my work. Even though there's a high comorbidity amongst this group, because they're low prevalence disorders, we really don't see as many of those as we do the high prevalence disorders for obvious reasons. So the challenges, and people have been talking about the challenges of comorbidity today. For the service user, we've heard different examples of the challenges that they're up against. But one of the things that amazes me is the burden of appointments that they have and how the heck they know what they're doing. The impact on their social system, and there was talk about from Raymond this morning about one of the things that some of the patients that he researched would say is they're most concerned about the social issues that are facing them, and in particular work or not being able to work and having no income. And the other one is that there's no single point of contact with the system. Nobody knows who to ring. And that's a problem. And I've been working with the cancer care coordinators in our hospital, who are the first point of contact for a person who's just been diagnosed with cancer. And it seems to be making a huge difference. But as again was mentioned this morning, once they're discharged from hospital, that's it. These cancer care coordinators are following some of those folk through in the community, but once they're supposedly recovered or in remission, they lose that contact. So there's a problem there. Hospitals are reductionist, and health services in general are reductionist. There's silos of specialist knowledge that often don't communicate with each other. They're emotionally charged and marked by poor communication and poor coordination, and we've heard lots of examples of that this morning. And I want to talk about Alice, and I think I saw Leslie come back in the room. Yep. Alice is from a mob down south. So I thought that was just coincidental. So your presentation was a lovely segue into what I was going to talk about with Alice. Alice is obviously a pseudonym, but she's a real person. And I first met her in 2006 when she was referred to us because of a restricted and very poor diet in the context of so-called brittle diabetes. There was a query about whether she had an eating disorder, and at that time she was 24. She had diabetes since age 18 when she was pregnant, and she was an insulin-dependent diabetic. She was a single mother of a 6-year-old daughter who I'll call Jo. She was 6 at the time. And what we found as we got to know Alice is that she experienced significant mental health, social and cultural challenges that simply were not being addressed, and there were a number of reasons for this. She was engaged with poorly engaged with the Aboriginal Health Service counselling arm, and part of the problem was that when we said that we were really worried about her, the Aboriginal Health Service counsellors would say, well, why? We have plenty of people with diabetes. I think you're worrying unnecessarily. They didn't see what we saw. When she came into hospital, she nearly died in front of our very eyes so many times. They didn't get to see that. They saw a reasonably well young woman out in the community, much the same as all their other clientele, and didn't understand what we were carrying on about. So it was really hard to engage them. And I don't mean to be critical of that. It was a contrast that I've come to understand as I've got to know Alice over the years, and I can see why they saw it that way, because Alice in fact saw it that way as well. When she was discharged, she was well, she thought. She didn't need to go and see these counsellors. She'd rather, go and visit her brother in jail, for example. That was more important to her. She wouldn't go to the counselling appointments. So she also felt things were fine outside of hospital, and when she was sick in hospital, then she'd acknowledge her illness. The community services didn't have an outreach arm, and if she didn't turn out for appointments or if anybody was worried about her, they couldn't go out and support her. And she wasn't eligible for public mental health services because she didn't have a low prevalence disorder. And in Victoria, the focus of public mental health services, and I guess across Australia to a certain extent, is low prevalence disorders. So people with personality disorder don't get a look in unless they're really, really at risk. That's improving, but still the services are pushed. So to get her into a case management service would have been impossible. So she just wasn't sick enough. What we also found was a very distressed and frustrated diabetes educator, and I think there's a few diabetes educators in the room. She was working what we call a HARP program, which was to keep people with chronic diseases out of hospital, basically, and try and help them stay well. And she was trying her best to coordinate the care for this young woman, but she was despairing because she was seeing this woman nearly die while she was in hospital and could not engage anybody in the community. So she was very, very frustrated. And then she found me and found out that I might be able to help. So together, and it's a long story, and I'm not doing Alice's story any justice, but the important point I want to make is even though it took a long time and a lot of hard work to get our coordinated plan together, it was certainly worth it. And as Dawn said this morning, collaboration is not easy, but it was certainly worth it. And I think we know what that collaboration looks like. So I won't go into all the detail of Alice's story because I don't know that, we haven't got the time, but it's a very rich story. But this is the biopsychosocial cultural formulation. It's very wordy, but bear with me. So she's a 34-year-old woman with complex biological, psychological, social and cultural difficulties, putting her at significant risk of ongoing complications and poorer outcomes. She's had multiple admissions. She spends about a third of her life in hospital, and that's been for the last well, since I've known her. So she's now spending more of that time in the mental health facility, though, than the diabetes ward. She's had multiple admissions, and these are often associated with increased psychological and social stresses. Her health problems include insulin-dependent diabetes, gastroparesis, peripheral neuropathy, vitamin D deficiency, recurrent UTIs, depression, constipation, hypercholesterolemia, appendectomy, previous left distal basilic vein thrombosis, end-stage kidney disease. She started dialysis in January, and mild cognitive impairment due to unstable diabetes and hypos and hypers. Significant psychological developmental difficulties resulting from childhood neglect and trauma, also known as personality disorder in some people's minds. So there's a lot more to the formulation in that. After that, we have a formulation that explains some of those psychological difficulties in more nurse-friendly terms, and they're also done in conjunction with Alice now. She's on board and understands the formulation, and we've worked together to use her words to explain her psychological difficulties. So we're combining our efforts to support Alice's long-term goals to become more self-sufficient and able to manage her own health needs, ultimately resulting in reduced admissions and better health outcomes. This relies on combining the biomedical, psychological and social expertise of the service providers to provide holistic care between hospital and community. And once we actually agreed on, a shared formulation, the community providers realised what we were so worried about when she was coming into hospital. They finally saw what we saw. And we got them on board, and we had been working on a collaborative approach for, ever since really, and it's been quite amazing actually. It's made quite a difference. So as we worked with Alice as we worked with each other in terms of collaborating in her care, we also worked with Alice. So we now also collaborate with her much better in terms of her care, which is partly a reflection of her psychological development that's occurred during the years of ad hoc therapy that she's had from me and the Aboriginal Counselling Service and whoever else has helped out at various times. She's now actually in mental health case management, or under mental health case management, however you would say it, and she's engaged with it. And sadly, she said to me at the end of last year, when she was heading for dialysis, she said, "I know you guys were telling me that this was going to happen, but I didn't hear it." A bit like what Leslie was saying, it was blah, 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 and now it's too late. And she's probably not got a long life expectancy on dialysis. She's not eligible for a transplant. So we're not sure how many years she's got left. But having said that, and she agrees with this, her acute hospital stays have decreased in frequency and length. She presents before she gets really sick. She's utilising her mental health supports in a big way. She's great in therapy. She's terrific. Her daughter still has a mum. She's now 16 and absolutely drop-dead gorgeous. She's still at school. She's not pregnant. She's not on drugs. She's receiving regular counselling support, and she wants to be a nurse, not surprisingly. And remember that when I talk about clinical supervision later on and what brings us to our work. And Alice is also very glad to be alive. So we're trying to change that next generation, and her daughter Jo is really stepping into being a gorgeous young woman, and we sort of feel like the village that's helped raise the child. So I did that in less than 15 minutes? Oh, good. So that's Alice's story, and I'm very proud of the work we've done with Alice, and I'll continue to work with her when I go back and start my work in the dialysis unit. And the diabetes educator is no longer involved because Alice doesn't fit their criteria anymore, but we do have mental health case management and we're working closely with them. So, and we now have the renal unit involved because she's in end-stage kidney disease. So she's still got a team of people around her who are looking out for her. So what I wanted to move on to is the second half of my presentation, which is around clinical supervision, and in particular clinical supervision for non-mental health staff. So this cartoon is from a book by Meg Bond on nurses' stress, and you might be able to relate to this. This is my head, these are my hands, and these are my legs. Together they do a million wonderful tricks. They make decisions, they get things done, they whiz around between patients and departments. They are always busy. This is my body. It's the wrong shape. It gets full of aches and pains. It contains my heart, which gets broken when I see people suffering, and there's not enough resources to really help. I have little to do with it as possible. Lucky for my body that I need it to join my hands and legs, otherwise out it would go. And I know I've done that, and I'm sure you can relate to that. Times where I just can't listen to my heart or my body because I've got things to do. When I used to work in intensive care, I can relate to that a lot. I just ran like a silly chook. The thing about working in healthcare and with human beings is it's demanding and intense and complex. But for me, that's what makes it privileged and immensely rewarding for me. And it's that emotional work that I love, and it's no accident I became a mental health nurse. So there's another concept I sort of wanted to talk about, and I know Kim Foster knows a lot more about emotional labour than I do, but now I've retired from full-time work, I'm going to do a lot more research into this area. And Ali Russell Hochschild, who I don't know if they're male or female. It's a woman. She was a professor of sociology and proposed the idea of emotional labour. Have people heard of it? Yeah, no? Yep. So this was in relation to air hostesses. So you know that stuff when you get on the plane, and I think you were talking about it before, feeling like an air hostess. Can I help you with that, sir? Oh, mind your head there. Yeah, just take a second. Seat up there. Hello. Yes. You know, that smile, that nodding, you know, making the person feel cared for. The work that goes into suppressing the fact that you really want to slug that person because their overhead baggage is too heavy and it's going to cause an injury. You suppress those feelings in order to put the face on for the other person's care and welfare, in order to do the work that you're there to do. And this was the concept of emotional labour. That has been applied to nursing. And I was reading something the other day that I had just been newly exposed to, was a paper by Sharon Bolton. And she studied she's a sociologist too, and she studied a group of nurses who described their work as emotionful, which I thought was quite nice. And she felt that the concept of emotional labour neglected the area of the work that we do that's attuned with the people we work with, that we're really not suppressing ourselves, that we're being genuine and present to their experience. And that's a really precious part of nursing work as well. And both is important. You know, in the middle of a cardiac arrest, you know, we need to stay contained and anxious, or, you know, a mental health crisis. We need to stay contained to keep our thinking caps on. But there's other times in our work where it's really important to be genuine and attuned to our patients. So I want to look at that a little bit more and understand that a little bit more, because I think that's a really important component of our work as well. But these concepts are really helpful in clinical supervision and when we reflect on our practice. And the general nurses I work with really appreciate these bodies of knowledge and helps them understand and put a frame around some of the struggles that they have. So reflection, which is core to clinical supervision, and I love this image because one of my supervisees, gosh, that's very possessive, one of the women who's a supervisee in our group, at the start of supervision, one of the nurses was talking about doing a public presentation, and she just said, "Oh my God, I don't speak in public. I don't do that. I don't do that." And I said, "Oh, you never know. You might get started and then like it and get addicted." "Oh, no, not me, not me." The other day I was in there, I went in there just to help prepare for this, and she was all excited and meeting up with someone. I said, "What are you doing?" And she said, "Oh, preparing for a presentation." And I said, "Oh, really?" And she said, "You know, I'm not nervous. I'm excited." And I thought, she's the little ginger cat looking into the mirror and seeing the lion. And she said, "I don't think without supervision I wouldn't have been able to step up to that." And it was one of those moments where I thought, that's really good. I felt so proud of her. And that sounds really paternalistic, I know, or maternalistic, I know, but I really did feel proud of her. She's the same age as me, but I felt very motherly towards her. Anyway, so reflection, a mirror imaging or producing a likeness upon which to contemplate. Mirrors also deflect light, thus the mirror imagery may also be illuminatory and assist in viewing the images more clearly. And Sally Garrett wrote that a long time ago, and I still like it. And she also went on to say that Reflection is the process of mulling over what has been experienced in order to understand more clearly the events which occurred, to identify what could have made the situation either better or worse, to critically assess the event by a process of breaking down or pulling apart, and thereby to extract some sort of meaning from the event. So the idea of reflecting on practice is a really important component of clinical supervision. So in clinical supervision, we talk about things that have occurred in the past. So we reflect on practice. And that then means that we become more skilled at reflecting in practice and before practice. And Dawn's gone, I noticed, but she talks about reflecting before practice. And I think that another joy that I witness is when people report thinking in the moment, when they're interacting with patients and feeling like they're really present to the moment. And I have a quote that sums that up from one of the supervisees in our group. And the thing about it is reflecting in the moment and being able to make sense of what's going on at the time, or at least be aware of what's going on for you, leads to more choiceful responses to patients in the moment, decreases reactivity and decreases impulsive reactions, and it results in a more helpful intervention. And I was thinking about that when Leslie was talking about know what your prejudices are. If you know what your prejudices are, you'll know, and you're reflecting in the moment, you'll know when they start to creep in. You might pick it up. You might know the gut reaction that you have when, because I have a problem with bad teeth, with people with bad teeth. I'd be hopeless out in remote areas. I know I have a problem with bad teeth. So I have to monitor that. That's the time where I have to put my, emotional labour skills into action. When I've got a client with bad teeth, I find it really off-putting. I know that. So they're helpful things to be aware of, and reflecting on practice helps us to become aware of those prejudices and stereotypes. And so I believe that this process of reflecting actually helps us mitigate against the emotional drain that we may feel in our work, and helps us to practice more mindfully and more fully present. Now, the other concept I really like is the concept of the wounded healer. And Chiron in Greek mythology was a centaur, and I don't know, but apparently centaurs live forever. And he was a teacher and a healer. And he received a wound from a poisoned arrow. And because he was immortal, he didn't die as a result of his wound, and he was destined to live in pain forever. And the idea of the wounded healer in today's world is a person who has suffered in his or her life. As a result of that suffering, the person has become a source of wisdom, healing, power and inspirations for others. And we see that all the time in the memoirs and the documentaries and interviews with people who have experienced challenging life events. And many of us in the helping professions have self-selected, and I don't know whether you've ever thought about this, in response to a wound that we may have incurred as a youngster. Or at least what we call in Gestalt psychotherapy a creative adjustment. So, for example, I'm the youngest of four. I was raised on a farm. Mum and Dad were always busy with the farm, and I learned pretty early that it was really good for my siblings to be in good nick, because then I'd be okay. If they were happy, then I'd be happy. If the group was okay, then I'd be okay. No accident I'm a psychiatric nurse. No accident I love running groups. No accident I love running support groups and supervision groups for nurses. I can see it. And so that's one of my creative adjustments. It doesn't matter. It's just to be aware of it. So, the wounds that we carry, it's not that they shouldn't be there or shouldn't exist. We just need to understand what they are and use them in the service of the folk we provide care for, and understand when they're tripping us up or getting in the way of our work. So Chiron, I find, as a concept that also is quite helpful in our reflective sessions, and many nurses have never thought about why they became the nurse, and that's a great question. That's a group topic I use sometimes. Let's talk today about what got us to nursing. What were the roles we took up in our lives that brought us into nursing? And this same nurse that's doing the presentation realised after however many years, she's in her 50s, same age as me, that she's been helping all her life. All her life, in all her roles, she's been a chronic helper. She took some time off this year, or last year, to just take some time out. She'd never done that in her life before. It was amazing, amazing. And again, she says she wouldn't have done that without supervision. So clinical supervision had its origins in psychotherapy training, and I know the term clinical supervision for general nurses is a problem. Some general nurses will prefer to call it structured reflective practice, and we have big debates about that, whether we'll change the name or not, but I'm sticking with clinical supervision today. And I use Kerry Hancock's and Lisa Lynch's definition, which is clinical supervision is a formal process between two or more professionals. The focus is to provide support for the supervisees in order to promote self-awareness, professional development and growth within the context of their professional environment. Now, that's a really important point, is it is not therapy and it is not managerial supervision. So ideally, the person you're having supervision with should not have any governance over you in terms of managerial reporting or organisational reporting in any way. So that's...
About 3 minutes.
Okay. So assuming a trusting supervisory relationship develops, this provides a safe space to explore the helping role and its impact on the supervisee. It's a safe space to be unsure, and I think it's a safe space to explore those dualling missions that Dawn was talking about this morning. So some words from the supervisees themselves, and this was just said to me on Monday. The penny dropped when I said, I finally don't feel like a fraud. Clinical supervision enabled me to get a sense of really being an advanced practitioner. The value of being able to anticipate potentially challenging encounters and patient reactions, reflect before going into situations and prepare for them, being able to reflect is another tool in my toolbox. Supervision has given me the confidence to establish boundaries around what is and what is not a part of the role, and assisted me during the ever-changing dynamics of being a part of a team, yet at times feeling somewhat isolated and underappreciated. By having the ability to reflect in this manner, I feel as though I don't spend as much time or emotional space processing my thoughts and reactions to patients or situations. This means I have room to offer more of myself as a nurse who is beneficial to the patients, which is beneficial to the patients who will hopefully have an experience that is more meaningful. And this again was just from Monday. Maybe I had blinkers on. I now see things from a different perspective, understanding myself as a person who is a nurse and how I react to things, for example, grief. It has helped me to reflect during my interactions with patients, understand what is going on. I somehow feel more available to the person, more present. And I said to her, would you have used that word, more present? And she said, oh no, that was my mindfulness training. So she went off and did mindfulness training as well. And just in closing, that's my email if anybody has any thoughts or comments or feedback for me. And that's a paper that I wrote with two supervisees, one mental health nurse and one cancer care coordinator, a few years ago, talking about our experience of clinical supervision for advanced practice. Thank you.